Hello, everybody. My name's Dr. Ashish Marwaha, and today I wanted to give a talk on monogenic autoinflammatory disease and an overview of that topic. I'm actually a staff geneticist at Alberta Children's Hospital and a clinical assistant professor at the University of Calgary, and I don't have any conflicts of interest to declare. I did want to give some credit, though, to a lot of the information and structure of the knowledge in this talk coming from a review that I co-wrote with Jason Ann and Ronald Laxer, who are two rheumatologists in Toronto. So the main objectives of this talk today are to describe the main features of several monogenic autoinflammatory disorders and to help recommend a genetic testing strategy if you're faced with a person presenting with an autoinflammatory set of symptoms in front of you. And how we're going to do that today is to start off by defining what autoinflammatory disease actually is and means, because the definition has definitely changed over the years. Talking about how to classify this big group of conditions into different subsections by pathology to make it a little bit easier to think about them. And then to focus on a little bit on when you have the clinical suspicion, the genetic testing in the assessment of these groups of conditions. And then I'm going to finish off with a case that the family kindly gave me permission to share of unspecified or unclassified systemic autoinflammatory disease that we have in my research program, and that hopefully will illustrate a lot of the points in the talk and illustrate the power of research within this complicated field. So let's start off with what is autoinflammatory disease, sometimes abbreviated to AID. So historically, autoinflammatory conditions were actually identified in the year 2000, so at the turn of the century, with the discovery of some monogenic conditions. So that means single gene disorders, familial Mediterranean fever or FMF, and another one called TRAPS. And these were a new set of conditions that seemed to affect the innate immune system, and that's why they were given a new name, autoinflammatory. But really, more recently, we've taken that term of autoinflammatory disease as more of an umbrella term for a number of conditions that result from dysregulation of what we call the innate immune system. So just to go backwards a step, the immune system has both the innate section, which is the first response, and the secondary, more antigen-specific adaptive section that responds specifically to viruses or bacteria by recognizing things on their surface. So really, autoinflammatory disease has come to represent a number of conditions under that umbrella. And although there may be secondary adaptive effects, really, they primarily lie within the innate immune system or the genes. And really, they cause these kind of recurrent attacks. So you can be healthy in between, and then suddenly you get these attacks, we call them, of abnormal or sterile, so no infection there, but an inflammatory response. So it's your body kind of reacting as if there was an infection there every so often, when actually there isn't anything there to fight off. And another point to make clear with the definitions is that many patients actually don't even receive a genetic diagnosis or a definitive diagnosis. And I would say that's actually the majority in the practice that I see. We send a lot of genetic testing and we don't get a confirmed diagnosis back. And there's this term that I like called undifferentiated or unspecified systemic autoinflammatory disease, or USAID. And that gives that set of people a diagnosis, because we still know they have autoinflammatory disease and autoinflammatory symptoms. We know vaguely how to treat it, and we know it's a serious medical condition. And therefore, having a name to it really does help with all of that. And so even when someone doesn't have a definitive genetic diagnosis, they can be given the diagnosis of USAID. So now that we have this new definition of autoinflammatory disease, although it began with a set of monogenic single gene disorders, I would say they're now a subset of the wider umbrella. And it definitely includes what we call polygenic conditions. So those are ones where there's multifactorial causes. So both the environment and some genetic risk is passed down. And it also presents across the age spectrum. So before we used to concentrate on autoinflammatory diseases being in kids, but we know increasingly now that there's a number that present in adulthood. And I wanted to emphasize that there's a huge pace of discovery of new conditions. So although lots of people fall into that undifferentiated USAID umbrella term, every year there's a number of genetic conditions being identified, and they eventually get a more confirmed diagnosis. And to illustrate that, I've listed a few genes here that are 17 conditions that within the past 2 years alone have been newly discovered within this field. And one important distinction to make from autoinflammatory disorders is what's the difference between them and autoimmune disorders, which more people have really heard of, both physicians and the general public. So what's the difference between autoinflammatory and autoimmune? Well, the autoinflammatory, as I said, is the innate immune system, and autoimmune tends to be more of the adaptive immune system. The autoinflammatory tend to be more monogenic, so single gene disorders, as opposed to the polygenic or multifactorial disease causes of autoimmune disease. And so when we send our genetic testing, we have more of a chance of finding a diagnosis in autoinflammatory disease. They present with some unique symptoms that aren't always found in autoimmune disease. So recurrent fevers or ulcers or bone inflammation tend to indicate more an autoinflammatory cause rather than autoimmune, although there are a lot of overlapping symptoms, and definitely one can be mistaken for another. The presence of autoantibodies is a B cell response, it's an antigen-specific response. Those antibodies are towards an antigen. And so as an adaptive immune response is more of an indication of autoimmune disease rather than autoinflammatory disease. So that's a good differentiator. If we have autoantibodies, we think about autoimmune disease. And when we have an autoimmune presentation, but the antibodies we're expecting are not there, might need to think about more of a monogenic or autoinflammatory cause. They're treated slightly differently as a first line. So colchicine is used in a lot of autoinflammatory disorders. It's a simple, cheap, and commonly available drug to try as a first line. Traditionally, first found to be effective in familial Mediterranean fever. And then there's a number of biologics which target IL-1, so anti-IL-1 antibodies, and other biologic agents, which are used more in autoinflammatory conditions as compared with autoimmune disorders, where there's a number of biologics that are used in both, actually. So now we're going to concentrate on how do we classify the monogenic or single gene forms of autoinflammatory disease by pathology, because that will help people think about when someone presents with a constellation of symptoms, whether they fit into one of these categories. And these are the categories here that we'll go through one at a time. So we're going to start off with the inflammasopathies. And the inflammasome is a cell structure that senses generic molecular motifs in bacteria and viruses, for example, that indicate the cell's in danger, and can also indicate tissue damage, and then trigger this immune response, which is an innate response. It's not antigen specific. It's just general distress of the cell. And that response is very much mediated by two cytokines, IL-1 and IL-18, which are activated through the inflammasome process. These disorders tend to present with things like fevers, rashes, arthritis, other body organ inflammation. And the IL-18 ones sometimes present quite severely with something called HLH, which is sort of an overwhelming body reaction to autoinflammation, and can end up with some people in hospital. The reason we mention IL-18 is because we can measure that in the blood. So when that's elevated, it gives us a bit of a clue that this might be an inflammasopathy-mediated condition. Some more common syndromes that fall under this umbrella that you should know about Our familiar Mediterranean fever, which we've already discussed, is very common, especially in certain ancestries of, say, Mediterranean origin, where the carrier rate is very high. And then another one that I think is worth mentioning is CAPS, or the gene is NLRP3. The rash you can see in this picture here is quite distinctive. So it's something that can be recognizable. And there's a spectrum of different severity conditions that fall under the CAPS umbrella with the same gene. But one thing that seems to stick out is that they can have the symptoms can be triggered by the cold weather. And then some of them also have hearing loss as part of the condition. And that's another way in genetics. They sometimes come to us through hearing loss panels as opposed to us knowing that the autoinflammatory features are the main ones. The therapy tends to be colchicine primarily for FMF and the anti-IL-1 therapies because the inflammasomes are often trigger the IL-1 pathway. The next set of conditions are called interferonopathies. So these are the type 1 interferons, so interferon alpha and beta. There are other types of interferons that can get confusing, but those are the ones we're talking about when we talk about the interferonopathies. And this pathway is interesting to geneticists because it's involved with the sensing and processing of nucleic acids, so the sort of building blocks of DNA. And when those are not processed correctly, you end up with the type 1 interferon pathway being triggered and a release of type 1 interferons. And a very common example that we come across in genetics, sometimes neurologists will also come across this, is Aicardi-Goutieres syndrome. That's a leukodystrophy that has white matter changes in the brain. And they tend to present with this rash called panniculitis, lipodystrophy, so rebody distribution of fat, vasculitis in the vessels, interstitial lung disease, calcifications. And then one thing that seems to be a little bit perhaps specific is the Chilblain rash in this case. And there's a picture of it there. Definitely can be seen in Aicardi-Goutieres syndrome, but is seen in other type 1 interferonopathies. An interesting tidbit is that COVID is thought, now that we know that some people were severely affected by COVID and others weren't, and it was more affecting adults than children more severely. We think that that might be because people had antibodies to type 1 interferons and that you gather those over life. And so people who had knocked out this pathway through antibodies were potentially also getting severe reactions to the same infection as other people who didn't have antibodies. And if you remember with COVID, there was a time when they were talking about this Chilblain rash on some people, and that's probably the link with the pathway. What's another interesting thing about the interferonopathies is that we do have a functional test that can be quite useful. It's mainly available on a research basis at the moment, but in Calgary, we're interested in making this into a clinical test potentially. And it's called the type 1 interferon gene expression score. And what it does is it just takes a number of the genes in the pathway and adds up their level of expression and gives you a score which has a cutoff. If you're above that cutoff, you're more likely to have a type 1 interferonopathy, and if you're below, you don't. And another reason that this sort of set of conditions is important to identify is that there's a targeted therapy. That therapy are JAK inhibitors. That's another part of the immune system that is downstream of the type 1 interferon pathway. And so when we have one of these being diagnosed, we have a specific targeted therapy. And we've already talked about the COVID link. The next category is NF-kappa Bopathies, or some people call them relopathies. And the NF-kappa B pathway is really central to a lot of immune responses. So although this is an innate sort of condition in terms of autoinflammatory disease, it really is a bridge between a number of immune system changes. And there's a number of genes involved in the pathway. One that I wanted to highlight that is a fairly new condition that just has been described as one of the ones in the past 2 years is in the NEMO or IKBKG gene. There's a specific deletion in exon 5, which causes autoinflammatory disease. And it's allelic, which means that there's other conditions that happen with changes in the same gene to something called incontinentia pigmenti, which is geneticists know well as a skin disorder. And it can be a fairly hard gene to sequence because there's a pseudogene, so a remnant gene right next to it that's almost identical. And so you do have to send specific genetic testing for this gene, which is done by a limited number of companies out there. Another NF-kappa biopathy to highlight is HA20 or hapless insufficiency of A20. The gene is TNF-AIP2. And that's important because it's a mimic of Behçet's disease that presents with oral and genital ulcers. So when you have an ulcer type presentation, this is definitely one of the things on the differential and a reason to do genetic testing. And they do tend to present with rashes, ulcerations, arthritis, uveitis, IBD or colitis more precisely, and can have immunodeficiency because they're connected. Again, this is such a central pathway. And the treatment that's specific to this group of conditions are TNF inhibitors. The next category is cytoskeletalopathy. Some people call them actinopathies because it's the actin cytoskeleton that we're talking about. And the cytoskeleton is important in a number of cells, but especially in the immune cells, it seems to be very important with the mobility of them, the way they eat other sort of bacteria or viruses, that's called phagocytosis, the way they form immune synapses and regulate immune responses is all important with this sort of skeleton in the cell that you can see in green in that picture there. There's again a couple of new conditions that have been placed on this category. I think it's going to be an emerging number of different conditions that come under this category in the future. But the one I wanted to mention was NOCAR, or neonatal onset of pancytopenia, autoinflammation, rash, and hematophagocytosis. So the clues in the name for what it causes can be quite a severe neonatal onset disease. The gene is CDC42. And the reason that I mentioned this in the context of genetics is that sometimes they get dysmorphic features or changes in the face. They look different. And so when we have a child in the NICU who's dysmorphic and has these overwhelming autoimmune response or HLH, we should sort of think about this condition. Another gene under this umbrella is ARPC1B, and that mimics Wiskott-Aldrich syndrome, which, if you remember, is something that heavily affects the platelets and causes cytopenias and immunodeficiency. And really in this group, actually, cytopenias are a common feature. So issues with the platelets, issues with other blood cell lines, maybe because they're not being formed correctly due to the cytoskeleton not being present in the right way. And interestingly, some of these also have an IL-18 increase. Again, we mentioned that because we sometimes can measure that in the blood. And therefore, when we have the IL-18 increase, we think of some of these cytoskeletalopathies. And we also, if you remember, think of the inflammasopathies that are mediated by IL-18. The next category is enzymatic deficiencies and an intersection with metabolic disorders that we also see a lot of in genetics. So the first one is hyper-IgD syndrome. The enzyme name is mevalonate kinase, and so it's mevalonate kinase deficiency. And it's a metabolic disorder that presents very much like the typical recurrent fever syndromes. It's on the differential for familial Mediterranean fever and other things. And what's interesting about this is in metabolic disorders, we also have a number of functional tests that we can use. And for these, you can measure the urine organic acids, and you would see mevalonic acid. That's a simple urine test to send. But you have to catch them within an episode or a flare. And you can see the sort of rash that presents in the hand on the right. And these are treated with anti-IL-1/2. Another enzyme deficiency that's worth mentioning is DADA2 or ADA2 deficiency. That presents with a vasculitis type rash, which you can sort of see on the right. Livedo reticularis, which is this sort of spiderweb pattern that we often see in little babies, but when you see it with fevers or even someone who's had an early onset stroke, you should definitely think about this condition. And again, the targeted therapy is there, TNF inhibitor. It's worth pausing briefly here to mention a local story that we had in Calgary, whereby there was a child who came in just with muscle pain, and the metabolic team were called to see her. And a very astute resident took a very detailed history and came out with a history of fevers or recurrent fevers. And they came up to me and said, "We'll send the genetic testing, just let us know what to send." And luckily, we sent a broad panel that had DADA2 on it. One of the smaller autoinflammatory panels did not. So we made sure we sent the right panel, and she received a diagnosis. And so she was able to go on to TNF inhibitor therapy, and that prevented her from getting strokes, which can be quite debilitating if that had been left untreated and unsolved for a long period of time. And because these metabolic disorders are in the same category as several other ones, people have thought about other ways to treat them. So replacing the enzyme is often a way we treat metabolic disorders. So that's one possibility. And gene therapy really is something that could come along with these fields, because you can replace a product that's missing, and you can input a gene that is able to produce that in any cell. The next category is an important new one, which is somatic changes. So this means that the changes weren't in the germline, so in the egg or sperm that formed someone, but they happened after the embryo was formed at some point. And so they're in some cells in the body, but not all the cells. And this sort of thought process was really accelerated in the field of autoinflammatory disease because of VEXAS, which the gene is UBE1, stands for vacuoles E1 enzyme X-linked autoinflammatory somatic disease. And it is purely a somatic entity. So when you look in the blood, you do see the mutations in UBE1, but they're not in all the cells. They're in some of the cells. And you can see that it's a great illustration of what autoinflammatory disease, or how people sometimes ask me, how does it present? When should I be suspicious? VEXAS is a good example of how it can present anywhere, and you should be suspicious of people with strange combinations of these things. So definitely fevers. Sometimes you get periorbital edema, so swelling around the eyes. You can get inflammatory eye disease, so red eyes. You can get hearing loss. We've heard about that being important in the context of CAPS as well. You can get problems with the lungs, something called neutrophilic alveolitis, pleural effusions in the lungs, a fluid on the lungs. You can get inflammation of the heart, some myocarditis. Sometimes we see recurrent pericarditis in autoinflammatory disease. You get problems with colitis, so IBD type symptoms. And for VEXAS, one of the more specific features that might make you suspect that is if you have problems with the bone marrow. So myeloma, cytopenias, and really that you see these vacuoles in the myeloid cells that you would see on pathology of the bone marrow. You can definitely get arthritis in this and a lot of autoinflammatory conditions. You can also get rashes, right? So the rash here is neutrophilic dermatosis, which you can see an actual genuine picture of there. But you can also get vasculitis type rashes. And in VEXAS, you also get deep vein thrombosis. It's an adult onset condition. So remember I said that the spectrum of age of onset is changing with autoinflammatory disease as we're recognizing them more in adults. That may be because there's a lot of somatic changes. And if the change is not in all your cells, but some of your cells, something that can present later on in life for sure. And as we look more and more and perform deeper and deeper sequencing of more cells, we're starting to pick out that in a lot of the other conditions that we've known about, there can be somatic versions. So CAPS, which I mentioned, which is an inflammasopathy, NLRP3, somatic has been described. NLRC4 is another inflammasopathy where there's been somatic changes described. And MEFB is the familial Mediterranean fever gene. And I saw a paper recently where even that has been postulated as some people having a somatic origin of disease. And so let's put that all together. So we've talked about the symptoms you would think about. And then we've also talked about genetic testing being more indicated in autoinflammatory disease when you have that constellation of symptoms. So I have a very low threshold to at least send a panel. And that even though you send the genetic testing, a number of people are still left undiagnosed or unclassified, and they come under then that USAID umbrella. But what is the genetic testing strategy when you get that set of symptoms? So the first thing is to think about single gene testing. I tend to only do that when I've got a good family history of a condition or a very classical case of familial Mediterranean fever with the right ancestry, and I want to start off with that gene. Otherwise, I don't tend to be so specific about sending a single gene test because a lot of them mimic each other, and you can have variable things if you have the same gene change in terms of experiencing symptoms. The main option that is available to most people in most provinces and is ordered not only through genetics but through rheumatology and immunology are gene panels. So that's a set of genes that we know cause autoinflammatory disease, but there are a number of them out there. And my advice is if you're going to send one that's as broad as possible. So the one example I gave of the DADA2 patient, if we had sent the smaller autoinflammatory panel, that's the more traditional known syndromes that were first described, we wouldn't have picked up that diagnosis. But we sent like a 642 gene panel that is at Blueprint. It's called the Complex Immune Cytopenia Panel, and that's quite a broad panel that covers a lot of things. And obviously, that means that you might get changes in genes that have no relation to your phenotype. But especially if you're a geneticist or someone sending these panels, you should know how to deal with those, which are called variants of uncertain significance. And if they really don't match the phenotype of the patient, you don't need to do anything further with those changes. And what I've moved to recently also is trying to get a gene panel that is done in-house, so done in the laboratory in Calgary. And what's been advantageous to that approach is that I'm able to add genes to that panel. So the one problem with a panel is that they're frequently out of date. So you imagine the 17 new disorders that I described are not on that panel as of 2 years ago. So you have to constantly keep an eye out and add genes. And what I try to do is keep an eye out for new genes, keep my panel up to date. And if there's a specific phenotype, I might look into that and see if there's any genes I need to add that on the panel. The next step up from a gene panel is to do what's called an exome that looks at all the genes at the same time, but it's often not funded by provinces clinically. And if it's not, I try and do it on a research basis. In fact, I send panels which are on the exome backbone. So they have that data there, they just haven't looked at it. I try and get it back and look at it myself in my lab. The next step up from an exome, which only show sequences the expressed bits of genes, is the genome that does the genes, the in-between bits, or the regulatory elements. And that's currently very much a research test, but is coming into clinical practice soon. And then you need to then think about somatic changes. So there is now a panel out of Washington that can be done on tissue, which looks for somatic changes in some of the immune genes. And so that is clinically available, but might be a little bit hard to access for some people. And then you're sort of thinking about also what other adjunct studies could you do? And they're all research right now, but maybe we are transitioning some of them to be clinical in the future. So one is RNA sequencing. So DNA goes to RNA, goes to protein. So you can look at the changes in the RNA to try and see if you can then find the changes in the DNA. That's something we're interested in doing in my lab. And then I also mentioned the type 1 interferon score. That's a functional test. We have some others as well that are useful. So we can do the cytokines, which you get the IL-18 level, and some other little tests that we can do of the immune system just to see if we can get any clues. So now I wanted to just sort of finish off by talking about a case that one of my families that I see has kindly allowed me to share, and really talk about how this was a case of unclassified or undiagnosed systemic autoinflammatory disease and how we progressed through it to try and figure it out and hopefully ended up with a treatment change that is going to make a difference. So this was a 15-year-old child with was like a sort of it was definitely an autoinflammatory phenotype, but it was initially characterized by periodic fever attacks. And they happen since the age of 4. But then subsequent to that, the fever sort of disappeared, but the autoinflammatory attacks continued. And so that sometimes confuses people. They're like, can you have autoinflammatory disease without the fever? And you do see that actually, that in some cases the fever is there, and in some cases is there sometimes, in some cases it goes away, but you get all the other things that happen with your attack. This was triggered by the stress and cold. And so that made us think of an inflammasopathy in CAPS. And that's kind of how this child was treated for a long time. There was rashes that were all sorts of different rashes. I'll show you pictures in the next slide. So hive-like, pinpoint cellulitis, right, maybe in the whole body. There was joint pain all over the body. There's periorbital edema. So remember, I mentioned that in the context of Vexus, but that can be an autoinflammatory syndrome, swelling around the eyes. There was abdominal pain, and there was recurrent croup. So as a child, I'm not sure if that was relevant because his father also had the same issue, but didn't have any of the other things. And we were treating it really like an inflammasopathy. So we had the child on colchicine, which sometimes helps with them, if you remember. Canakinumab is a anti-IL-1. And there was a partial response to that. So, but then more recently, there's been an ongoing rash and ongoing episodes. Definitely all of these conditions, I didn't mention this before, do respond to steroids, but that isn't a long-term therapy because there's so many side effects from being on long-term steroids. Steroids just sort of cut the whole immune response. So obviously, most of these just respond to that. There wasn't any other real big clues in the family history. The parents really, I would say, did not have the same thing, and there were several healthy siblings. In terms of the exam, like you'll see when I saw this child, there was the rash was actually there. And interestingly, there was this case of unilateral gynecomastia, which may or may not have been relevant. Otherwise, the fat distribution was all normal. We did a number of immune investigations. So remember, I told you there's a number of things we can do to check the immune system. So we did immunoglobulins A, G, and M. Those were all normal. Interestingly, he had a slightly high IgD. And remember, I mentioned that syndrome, hyper IgD syndrome. And so people got excited about that, but that didn't pan out to be a consistent finding. And, as I mentioned, you can treat that as a metabolic disorder and do a bit of workup, and it never panned out either on the genetics or metabolics. So that hyper IgD was the diagnosis here. And then we do have like flow cytometry panels to look at the immune system and the cells. There were some minor perturbations, but nothing to write home about. And like most autoinflammatory diseases, the inflammatory markers, so CRP is one of them, ESR is another, they go up during the episodes and then they come back as normal in between. And the child is normally doing well in between attacks. These are some pictures. So you can see there was like hand swelling. There were these different rashes all over the body. There's a picture of the gynecomastia there. Some of the rashes look like they're indented, almost like a peau d'orange type finding. But you can see the variety of rashes that were presenting in these attacks. And so we did the standard genetic testing, some of which we've talked about already. So this person had a panel, which was negative. We didn't find anything of that. They actually went on to exome. I think that was because they came into hospital and were really sick. And sometimes in that case, you can get clinical approval to do exome. It's ironically easier to do that when someone's sick and in hospital. But it was negative too. And so we really needed to move them into a research pathway, and some funding through a national collaboration called Care for Rare became available to us, and we got the child genome sequencing through this collaboration. And what we found was 2 variants. In trans means one was inherited from dad, one from mum, and so they were on different alleles. The first was a variant that's like just before the gene starts, but it has been seen in other cases of what we call Candle or Prass syndrome. I'll go through what that means in a bit. And then there was a second intronic variant. So it wasn't in the gene, it was around the gene. And we're not sure if that is the genuine second variant or whether it's a red herring, but for what it's worth, there were 2 variants there. And this is thought to be the sort of condition where you do need 2 variants, one on each copy, one from mum, one from dad, to stop the gene working on both. So what's Candle syndrome or PRAS syndrome? So Candle stands for chronic atypical neutrophilic dermatosis with lipodystrophy and elevated temperature. PRAS stands for proteasome-associated autoinflammatory syndromes. They're the same thing. And it's a type 1 interferonopathy. It's not one that I mentioned as an example because I wanted to leave it for here, but it's also one of those type 1 interferonopathies. It presents with, you can see the periorbital edema, which if you remember he had, the fevers, lipodystrophy, which is fat distribution, which is normally quite severe and obvious, but in this case, there was only that unilateral gynecomastia, which I'm not sure it fits in or not. And you get this specific rash called a neutrophilic dermatosis. We talked about that in the context of VEXAS, but it also is part of Candle syndrome. And so often you can see that on pathology. And it's caused by genes that are involved with the structure of proteasome in the cell that is another sort of pro-inflammatory processing of material in the cell that induces an autoinflammatory response. Another thing to mention is that there's a group of genes here, and this is one where there can be digenic inheritance. So variants in two different genes come together to stop the proteasome working. And so we had a good look at the other set of genes, some of which are within the 2 years have been discovered. And we only found those two variants in the same gene that were suspicious to us. So I often do this with people who I see, where I'll take the child and describe the features, and then take the condition and describe the features, and in the color sort of mark where I think there might be overlap. So what was fitting here with Candle or PRAS, which is the PSMB4 variants that we found, were the recurrent fevers. There was this skin rash, and but in the condition, it's maybe a little bit more specific. We wanted an expert to look at the pictures to give us some guidance. We weren't able to get that done in time for this presentation. When they took a sample and looked under the microscope, the pathologist did think there were some similarities to the published cases, but that's difficult having not seen one themselves. There was a periorbital edema, which I said could be in some other syndromes, but was specific here. And then there's always been joint pains. There's a question mark over whether the gynecomastia represents a mild form of lipodystrophy. And there's some things that happen in the condition that the child did not have, and there's some things that the child had that aren't really described in the condition. And so remember I said for the type 1 interferonopathies, we can do a gene expression score, and this is what that looks like. Again, it's on a research basis. This was sent to the NIH through some collaborators, kindly agreed to do this. And the child is on the far right, along with two others in that red box that have other diagnoses of type 1 interferonopathies. And in the green are a bunch of controls, one of which we sent with the sample. And these are the list of genes that are expressed in the type 1 interferon pathway. And as you can see, the child clusters with other patients with type 1 interferonopathies. The signature looks more similar to them than the controls. Again, remember, we can put this into a score and have a cutoff. And so we think that this was indicative of an issue that diagnosing him with an interferonopathy as opposed to the inflammasopathy that he was originally being treated for. As I mentioned, the skin biopsy could have been consistent. And I think one of the most important steps here is that in Calgary, we have a complex immune dysregulation program that was started up by myself and some others, where we have input from genetics, dermatology, immunology, rheumatology, and we can discuss this sort of case. And we can say, look, this is all the evidence we have. This is the stuff we have from our research genetics. This is the stuff we have from other research. This is how the person is presenting. Do we think there's enough evidence here now to possibly treat this person differently? And the consensus was that there was. And so this was the treatment change. So the patient was originally on an anti-IL-1 biologic, the canakinumab, because we were thinking of it as a cold-induced recurrent fever syndrome. So it was maybe something like CAPS, even though we never found a gene change. And what we were switching him on to is a JAK inhibitor, which is a treatment for an interferonopathy, type 1 interferonopathies, and is used in Candle and PRAS. And it's currently undergoing that change. We're doing it very slowly in a stepwise process. And the last I heard were that things were going well with that change. And we're hoping that this is a better treatment that holds the symptoms better for this individual than the original treatment was doing with breakthrough rashes. So some take-home points from the case. For unclassified or USAID, where there isn't a diagnosis from standard genetic testing, whole genome sequencing could be useful because it would find intronic variants that aren't seen in exome analyses. And genetics informs the treatment sometimes. And so there will be treatment changes that come from having a better test. You can see that although we found 2 variants in that gene, it wasn't a slam dunk. And we needed to do what's called phenotyping. So match what the patient had to the condition, try and get experts to come in and weigh in on that. And really, that isn't the role of a geneticist by themselves, because we aren't often the sole experts in these conditions. But rheumatologists, dermatologists for the rashes, and immunologists for the immune system are the experts. And often they can help with that, going back saying, we found something on the genetics. Do you think it's a fit for this condition? And that's why we have this multidisciplinary rounds approach to dealing and discussing with these cases, which I think is one of the most valuable things we have in Calgary that isn't exactly mimicked elsewhere in the country. And then, as you can see, when you do something like a genome, which is on the research level, you're going to get lots and lots of candidates in various genes, which we filter through, and sometimes functional tests to tell you whether those genetic changes are relevant or not are important. So we just had an example of the type 1 interferon gene expression score, where that was elevated in patients. It gave us more confidence to switch the treatment. The skin biopsies perhaps being useful when there's a specific finding that's associated, like neutrophilic dermatosis in Kendall-Prass or Vexer syndrome. And we're still in this case thinking about doing RNA-seq to look at the RNA sequencing and looking at the effect of those PSMB4 variants on the RNA. Because if the one intronic change, it should, if it's generally that's the answer, be affecting the RNA because that's coded for from the DNA. And so I'll leave it there. And I wanted to thank the members of my lab and people who have been with me as summer students and analysts who've looked at a lot of this data, and especially other people in the complex immune dysregulation program locally in Calgary, including Marinka Twilt, who's a rheumatologist, Luis Magria Favea, who's an immunologist, Nicola Wright, who's an immunologist hematologist, Michelle Ramian, who's a dermatologist, and Tatiana, who's one of our clinical fellows. And the type 1 interferon score was done by the NIH, so I wanted to pay credit to Ivona there for doing that. Often people do this out of their own research funds, and they don't charge you for doing this because they know they're helping an individual or a patient at the end of the day. And the funding for the genome definitely came from Care for Rare, which our local person for that is Dr. Francois Bernier, and I've been supported by Alberta Children's Hospital Research Institute startup funding, and the Summer Student Award for the summer student working on things. And really, I wanted to pay tribute and thanks to all the patients that I see and other people see and their families. I think there's a number of organizations now, and I know this talk is for the Canadian Autoinflammatory Alliance, that are really spreading great awareness of this set of conditions, which I think if you take them as a whole are fairly common and fairly commonly misdiagnosed by people in the community, and there's not enough education around this. So this has been a talk that's very much guided at more of a complex, maybe even physician or geneticist level, but I hope that anyone it's still accessible to a number of people, and it makes people think when they have sort of a strange constellation of symptoms which are multi-system and inflammatory and have fevers and ulcers and bone inflammation and redness and swelling and joint pain. They start thinking about, could this be an autoinflammatory condition? And I think the first step is to get a referral to a local rheumatologist. In most provinces, we have rheumatologists now who are interested both on the pediatric and adult side in running specialist clinics for this. And at some point, you may also be referred to immunology. And in Calgary, you would definitely be referred to me in genetics. And there's a few of us across the country in Canada that definitely have an emerging specialist interest in this field. And along with the patients forming their own alliances and patient organizations, we hope to form a network that will get more people to a diagnosis and to a right treatment where we can. So thank you very much, and happy Rare Disease Day for all those that celebrate on February 29th.